Hello and welcome. A study on vaccine efficacy conducted by the Gangaram Hospital in New Delhi has shown that a double dose of the Covishield vaccine is about 67% efficacious against the COVID-19 virus or disease. A single dose is only 30%. And we are obviously now talking about the Delta variant, which is the newer variant. There are many studies which have been done which test the efficacy of the vaccine, but not as many in India. A study, for instance, done by the Public Health Scotland says that the efficacy is only between 25 and 60%. It's a very large variation. So let's try and understand that a little better. Also, the good news is that the vaccines can have shown to be about 97% effective in preventing deaths. The same study, 93% against symptomatic infections, 89% against moderate to severe. So there are a couple of questions that arise. So one is, how do we interpret this study as normal people, as potential patients or recipients of this dreaded disease? Secondly, what does this mean when we look ahead? Does this mean that we need more vaccines, or do we need different vaccines to protect us? Or is there anything called full protection or even close to full protection? And therefore, we should be really happy with whatever we've got. So to understand that, I'm joined by two experts. One is the author and the lead of this study, Dr. Ruma Satwik from the Department of Obstetrics and Gynecology at the Gangaram Hospital. I'm also joined by Dr. Chandrakant Lahariya, epidemiologist, vaccinologist, and author and columnist. So thank you both for joining me. Dr. Satwik, let me start off with you. So this sample study looked at about 4,266 individuals and is mostly from around the month of May, which is the second wave of COVID-19 in India. So now tell us about why or how this study is strong, and to what extent should a person like me who doesn't know anything about what's going on believe it, or to what extent should I be even careful or skeptical about such findings?
So the study idea was generated by what we were experiencing. There were several anecdotal reports and reports based on what we were seeing that fully vaccinated individuals were contracting the infection as well. What we needed to know was how much the vaccines are protecting symptomatic infections and serious outcomes, and which is what initiated the study. Healthcare models or hospitals are the best places to perhaps conduct such studies. So we undertook this study. It has a cohort study design. Now you have to understand that this is perhaps one of the strongest study designs that exists to study real-world vaccine effectiveness. What it does is it divides people into three groups, one which has received 2 doses, the other that has received a single dose, and a third which has not received any doses at all, and compares outcome after a very robust follow-up of participants in the 2 doses versus the unvaccinated. So basically what the baseline rates are, it will try and tell you how much it is protecting from those baseline rates in terms of outcomes of interests that we studied. Now, the other thing that we have also done is not just made it a hospital-based record study, which means that we are not relying on hospital-based RT-PCRs alone. We are not relying on hospitalized patients alone or hospitalized healthcare workers alone. And the reason for this is that we understand and we saw with our, in our own experience, that many people who required beds in a city like Delhi did not find it. Even though the hospital provides equitable access to free healthcare to all its employees, irrespective of their designation statuses, there was these 2-3 weeks where people could not find beds. So if we had based our study only on hospitalized individuals, it would have missed out a significant chunk of people who would have still been at home. So this study relies on follow-up of participants who are all of them, and which is why we feel that it has a very robust study design. The third thing I'd like to say is the statistical analysis. The statistical analysis is what we call a confounder adjusted analysis, right? So if there are influences from factors like previous infections, and previous infections, as our study shows, has an independent protective effect on preventing all serious outcomes. So if you are doing a confounder adjusted analysis, the protection that our study is showing is actually speaking for the vaccine alone. It is not taking into account or it's showing the effect of vaccine alone, right? So based on this, when we say that 2 doses are offering a reduced protection against Delta, it's not like I don't want to take away from the protective effect of vaccines per se. So vaccines are protecting against serious outcomes, but they don't seem to be protecting against symptomatic infections. That rate is
Right.
significantly reduced, right? The second thing we are saying is that single doses in the context of a Delta surge are not doing much in terms of protection.
Right. Okay. Dr. Lahariya, let me pick up using this study as a start point in terms of how you see now the spread of the disease, the fact that the second wave has receded, and where we are in the overall, the battle in terms of the vaccination that we've achieved and the seroprevalence that we've achieved and the distance that we still have to travel.
Sure.
So thanks. First thing is that we need more of such studies to understand how vaccines are working in a real life settings. Having said that, what we also need to be mindful when interpreting such study, that what are the study settings. So for example, Sir Gangaram Hospital study, which Dr. Ruma has led, is mostly focused upon healthcare workers in a setup which is very controlled and where there is a high level of exposure. So this is an important study for that particular population, but we can or we should be a little careful in comparing with other setups such as Public Health England study, which has been done in general population, because the exposure in those populations are very different from the exposure in hospital setup. So that's the first caveat we need to remember. Second part is that what we need to remember that we should not worry too much about all symptomatic infection, because we know that vaccines prevent from moderate to severe illness, and that's where we need to see effectiveness rather than any symptomatic infection. Mild infection, we know vaccines do not prevent, and there is no value in that. And third part is, so as and when we compare all symptomatic infection, the efficacy or effectiveness in the real life comes down. That is not a concern for me, and that's what everybody is talking about. Coming to single dose effectiveness, I would again caution about this thing, because that depends upon various parameters. We know that vaccines work and they take around 3 weeks before developing antibody, and the approach to measure the effectiveness against single dose is very different. Like for example, what Public Health England did was a sample size of thousands of people, hundreds of thousands of people, or millions of people, and that's how we know very different than hospital setup. So we need to remember all those caveats, what this study shows and what we already know, that vaccines are working against moderate to severe illness and mortality. That's what the purpose is. The final point I would like to flag, that Delta variant is of course highly transmissible, and we know that when this study was conducted and vaccination was happening, Delta was the most commonly circulating variant. So the mere fact that the vaccine effectiveness against the circulating variant is very similar to the previous variant which was found during the efficacy study is very similar. So that's very assuring to me that we don't have to worry, and all people need to do get first shot of vaccine, then second shot of vaccine, and then keep following COVID appropriate behavior.
So just if I were to take a step back, Dr. Lahariya, what you're saying is whether it's from this study or Public Health England or Scotland, overall you're more than happy with what the vaccines are seemingly doing right now in terms of protection. Have I got that right?
That's very correct. So a mild symptomatic infection or asymptomatic infection, we are not worried about that. The purpose of vaccination is prevent moderate to severe illness, which essentially means hospitalization and mortality. And this study has found that this vaccine is working against moderate to severe illness and mortality, reducing hospitalization. So this is very same. And that's what we have found in the United Kingdom also, and United States. And whenever people were vaccinated, even with the increase in the Delta variant, the number of hospitalization has come down drastically, though infections were high. So this is very assuring in my opinion.
Right, and let me get an inside hospital view, Dr. Satwik. So, if you were to look at now any disease, and I hope I'm not blindsiding you here, but if you were to look at any disease, any prevention, any vaccine, how does this stack up? Just as someone who sits inside a hospital.
See, the study does not take away from the importance or need for vaccines. And like Dr. Lahariya correctly identified that this study is saying that 2 doses are working, right?
Yeah.
What is, I think, the other difference between our study and other studies is that other studies have shown some protective effect of a single dose, right? And perhaps in some sense, the previous studies and trials on single doses have led to a change in vaccine policy and a prolongation of the interval between first and second doses. Our submission here through our data analysis is only this, that if you are anticipating a surge, and especially in areas where seroprevalence is low, you are better protected with 2 doses than with a single dose, right? It will not be prudent to allow unprotected, susceptible populations to rely on the effect of a single dose alone. And this is
Right. Okay. No. So my question is that, when we say it's something is 97% effective in preventing deaths, 93% against symptomatic infection, I'm just trying to understand, how should a layperson interpret it? Is that very good? Is that what best Western medicine can do, or any medicine can do, to keep you protected against a pandemic? Or is this a halfway point? I'm just trying to interpret this in simpler terms, if that's possible.
Okay. Yeah. See, yes, in terms of deaths, in terms of moderate to severe disease, I think it is achieving its mark. It could have been better with respect to moderate to severe. We have shown an effectiveness of 75%. But if you look at the confidence intervals, which means that if the same study in similar circumstances using the same methodology were to be done in 100 such studies, you'd find that there is a lower bound and an upper bound, right? So the lower bound, and which is what I'm saying, that it could be lower, it could be higher. It may not be at 75. We have shown a protection. But you have the world's data to consider. It is not just this vaccine. It is mRNA vaccines. It's everywhere else. Studies have repeatedly shown us that efficacy or effectiveness against, symptomatic infections, against hospitalization is lower with respect to most vaccines. So it is the virus which is evolving. We have to understand this. And vaccines, I'm saying, as they should evolve with the virus.
Right, and it's good to always get an inside the hospital, because that's where the patients come, and then outside the hospital view, which is more epidemiological and a public health point of view. So let's look ahead now. So Dr. Lahariya, let me start with you. There is now talk about booster doses that in some ways, and of course it's in some countries, we're not talking about it in India right now, but are we now looking at a situation where it is possible that the vaccine efficacy may not be as long as we thought it would be, or maybe it was supposed to be only for a year, and therefore we should be thinking about booster doses?
So before I come to the booster dose, let me talk briefly about the findings of this study once again. One of the point we need to remember, that finding of any study are applicable for the study population in which the study was done. So for example, this is for hospital setup, so we cannot generalize this for general public. Sure. And so there is a limited value for making policy decision that how general population should be vaccinated. That's one. Second point is that the 75% effectiveness against moderate to severe disease is really very good, which essentially for general public means that of the vaccinated people, the rate of infection was 75% less than those individuals who were not vaccinated. 97% effectiveness against hospitalization essentially means the rate of hospitalization in vaccinated is 97% less than those not vaccinated, which is really big number. We need to remember that WHO had set up a cutoff of 50% for this one. Moving to booster dose, I personally believe that there is emerging evidence that people who develop natural infection are likely to have antibody and protection for really, really long. Like there was just one study in Nature on 24th of May, which identified that even after 11 months of recovery from the illness, people had antibody and they were probably protected. We are also seeing that we know that there are two things. One is antibody-based protection. We know antibody level goes down with the time, especially after 4 months of vaccination, antibody level goes down. But whether that translates into reduced protection or not, we do not really know because we do not know correlates of protection. Similarly, there is a T cell based response which assures us that person is likely to be protected. So in my opinion, this is little too early. That some of the countries, based upon very smaller studies, and especially Pfizer, BioNTech, and other companies are saying, based upon a study which are on 20 to 100 people, that subsequent shot increase the level of antibody, and which is likely to provide protection against Delta variant. But those are not enough scientific evidence to argue for booster shot. That's one. Second part is that vaccination program, and I often make this point, the vaccination program are always a combination of scientific evidence and operational feasibility. And we know that we don't have enough scientific evidence to argue for a booster shot. And there is the operational part is that there is a large part of the world population which has not received even a single shot, and they are still waiting for their vaccine. So world should be thinking globally and together supply of the vaccine as a single unit, and people should be receiving their first and second shot before booster shot can be considered. The final point I would like to flag here is that I think we need to separate two parts. One is that there is some specific population which require a third shot, and that's immunologically required, and that's a part of the primary immunization schedule for some immunocompromised and some people. That should not be considered or equated as a booster shot. That's a different story. But give completed immunization schedule for people who need only 2 shots and then giving them booster shot, world is not ready, and there is not enough evidence, and probably that should be delayed. And India should.
What would you say is the percentage or the proportion of those who are immunocompromised in any normal population?
I believe that would vary from different settings, but I think that the number should not be more than 2% of the total adult population, or even of the 2% of the total population in any setup.
Right. Dr. Satwik, let me sort of get an inside hospital view again. Now, many people in India were vaccinated in the month of January when the first vaccines started coming in, and doctors, particularly frontline workers, were being vaccinated. So those are the people who've already now, maybe if it's a year, should be gearing up for a second shot. What's your sense from within? Are you able to glean? I know there is no study, so therefore this is not a scientific answer that I'm expecting. But are you able to glean whether those who were vaccinated much earlier need another one, or does it look like, the vaccine is still working?
Yeah. See, we will only know this in the context of a third surge, as and when that happens. But I can tell you that studies are underway from the microbiologists within our hospital that look at antibody decay with time. And very soon we should be out with that data. That's a different set of authors. Looking at whether booster shots would be needed, I would say if natural infections are giving you the highest protection as of now, and there can be reinfections within, after 6 months. 6 months is the minimum duration that we saw that they were protected from a reinfection. It is entirely possible that the effect of vaccines may wane after a certain time.
Right. And Dr. Lahariya, let me come back to you. This is again a general vaccine question, right? How long do vaccines last? I remember taking a yellow fever vaccine, I think, when I was traveling, and that was supposed to last for 10 years. Many vaccines we take as children last almost forever, or are supposed to last forever. So if as a layperson, I were to ask you that question, what would be the answer?
So that is something which continuously keep evolving based upon scientific knowledge. For example, you gave yellow fever as an example. For the initial protection was given, or people were recommended that after 10 years they need to take yellow fever vaccine. But now the current evidence say that once you have taken yellow fever vaccine, it's provide protection for lifetime. You don't have to take second shot ever. Similarly, for hepatitis B, earlier there used to be dialogue that people need to take hepatitis B booster shot after 10 years or so. But current recommendation is that once you receive 3 shots of hepatitis B vaccine, it will provide lifelong protection. So it varies from different vaccine for different vaccines. For similar, while the flu vaccines are required, regular annual vaccine shots are required. So it varies. However, in this case, I personally think that we are still developing some better understanding of virus and disease and protection. But what we know that whenever we are in the high transmission period, or when the pandemic is happening, people are getting naturally infected. They might be protected for probably for long, possibly lifelong. but people who got vaccinated. But we should also assume that virus is circulating, and then some of the re-exposure people can be getting happening. So that may essentially means, as long as we are in the pandemic, the individual may not need a second shot except for high risk population or some identified groups, but healthy individual may not require a booster shot in the subsequent period. So what I think, based upon current knowledge, that primary immunization should reach to each individual, and then booster shot may or may not be needed, possibly may would be required for high risk population 2 years or something. Current evidence is that it's not required within 1 year. We don't know after 1 year what happens, because there is not that much time gone by since vaccination started.
Right. Last question to you both, and let me start with you, Dr. Satwik. So, the second wave has ebbed. We are under 40,000 or there around 40,000 cases a day, lower than some other countries which were lower than us earlier. This is, of course, not a sign for celebration, but it just tells us that it's ebbed, and it's definitely much more under control today than it was earlier. What are you seeing today, which are early signs of not necessarily another wave, but of any possible change in the way the virus is behaving or the way the virus is moving at this point? Dr. Satwik.
I think Dr. Lahariya is best placed to answer that. But what I can say is that the hospital admissions of COVID are at its lowest. They have been there for the past 1.5 to 2 months. It will depend upon how we behave in future. It will depend upon how much the vaccines are able to protect us beyond 6 months of use. Most people at this point would be at 6 months from their first dose. At least most healthcare workers would be at 6 months. So I think a third surge, if that happens, my sense is that it should not be as much as what we saw in April. Because the susceptible populations would be much, much lower. However, one needs to wait and see what it is like whenever this third surge happens. Yeah.
Right. Dr. Lahariya, last word to you. As you look around, as you look at data, as you look at anecdotal evidence, as you talk to people, what is the sense that you're getting right now?
So what we need to remember that before the start of second wave, India had around 75% of population which was susceptible, because we know through third zero survey around 25% of population had developed antibody. With the end of this current, or rather after the fourth nationwide zero survey, we know that 67.6% of the total population had antibody, and that was midpoint of 25th of June. And since then, additional population has been vaccinated, so we can confidently assume that 75 to 80% of population would have some form of protection, either from natural infection or after vaccination. So susceptible population has come down. With all of this and current knowledge, we can say that if and when third wave or subsequent wave would happen, it would be far smaller. The worst case scenario by some of the groups, Sutra Consortium, are saying that worst case scenario is that around 150,000 daily cases, and the realistic scenario is 70 to 80,000 daily cases. So we can be really hopeful that it would not be really that bad, but that does not mean that we can be carefree. We need to follow precautions as we are still evolving our understanding, and keep following mass behavior. But final point is, it will also depend upon whether a new variant emerge. We know scientifically that a same variant, Delta variant, which caused second wave, unlikely to cause another wave in such a short succession. But if a new variant emerges, the situation scenario could be different. And as long as virus is circulating, there is a possibility of new variant. That's why we need to be careful. But we can be assured that wave will be definitely far smaller than previous one.
Right, and vaccines will continue to work. On that note, Dr. Satwik, Dr. Lahariya, thank you so much for joining me, and I do hope to speak to you both again. Thank you.
Thank you, Dr.